Thank you very much for this very nice introduction. Thank you for the invitation being here with you and to share with you this Congress and science. And it's a pleasure and an honor to introduce Professor Allan Young. Professor Young is the chair of the Mood Disorders Unit in the King's College in London, and jointly he's the director of the Center of Affective Disorder in the Department of Psychological Medicine at the Institute of Psychiatry in London. But not only this, he has some more academic appointments, for example, at the University of Oxford, at the University of Newcastle, and also in Vancouver in Canada. Before, he was chair of the psychiatry department at the Imperial College in London. And he is the president-elect of the British Association of Psychopharmacology. His research interests focus on the pathology and treatment of severe psychiatric disorders, in particular affective disorders. He received many national and international research grants, and he published more than 350 peer-reviewed publications and additionally a number of books. He is also a member of several editorial boards of scientific publications and a member of many scientific and professional societies. And he is also the chair of the Psychopharmacology Committee of the very well-known Royal Society of Psychiatry. And we're looking forward to hear today his speech on diagnosis of mood disorders and the implications for research. Please, Professor Young.
Dankeschön, Herr Professor, and Teshkuradum. Thank you to the organizers for inviting me. It's very nice to be at this meeting again and to see how powerful and rich psychopharmacology research is in Turkey. I'm a clinical psychiatrist who is also a psychopharmacologist, but today I'm going to be talking about diagnosis and classification, because not only is this important for clinical practice, it is also important for our research, and I hope I can make that point clear. These are my disclosures. I'm employed by King's College Hospital London. I'm a consultant in the Maudsley and Bethlehem hospitals. I am involved with the pharmaceutical industry. I think the pharmaceutical industry is our best hope for new treatments. I chair the experimental medicine and clinical trials cluster of our research centre, and so on and so forth. I'm also president-elect to the BAP. I become president next summer. And it's particularly a pleasure and an honour to be here with our sister organisation, the TAP. The BAP has its summer meeting this year in Harrogate. Next year it is in London. Harrogate is rather difficult to get to, but London is very easy. The summer meeting is really multidisciplinary. We have basic scientists, we have clinicians, we have clinical trials, we have industry, and so on. So these are some of the topics which are available this year. We have a keynote lecture from my colleague, Professor Sir Robin Murray, and of course we have a very powerful preclinical psychopharmacology. The BAP also takes great pride in our clinical guidelines. The latest, which has just come out, is for perinatal disorders, and these are available free to download on our website, bap.org. So, to go to diagnosis and classification, unlike many psychiatric disorders, mania and melancholia were recognized in the early stages of scientific medicine by Hippocrates. And mania and melancholia have been recognized in many different parts of the world in classical literature. This is not just European, this is also true in the Arab world, in South Asia and in East Asia. Hippocrates also very importantly referred to these as brain disorders, as opposed to the seats of the soul or consciousness being in the diaphragm or the thymus and so on. And the key text for this is this wonderful book by Professor Morenos and Angst, who goes through the historical background to this. This is important because many of our psychiatric disorders are relatively new, and it's questionable whether they're newly recognized or entirely new. So, for example, schizophrenia, Hare in the Maudsley pointed out that there were really no accounts of this in pre-industrial societies. And this is still an open question and has led, for example, Robin Murray and others to think that psychosis or schizophrenia may be particularly linked to the social environment and urbanization. But this isn't true for mania and melancholia. So this is the great quote from Hippocrates, that from the brain come nothing else but joys, delights, laughters and sports. And this is the seat of the mind and its derangements. This, of course, is not to in any way diminish the importance of the social and cultural environment, but nevertheless to say that your slogan of minding the brain is very apt. And this is also recognized in my own hospital. This is the Maudsley and this is the Bethlehem. The Maudsley is a relatively recent institution, being built in World War I and being requisitioned by the military for the first 8 years. But the Bethlehem is the oldest continuously existing psychiatric institution in the world. It dates from the 12th century in the UK. And it's occupied a number of different buildings. This is the present one, which is in Kent. The second building is now the Imperial War Museum in London, and above its gates was this statue, which is now in our Museum of the Mind in the Bethlehem, entitled A Raving and Melancholy Madness. And this is the same individual in two very different phases of the same illness, what we would now call bipolar disorder, which was previously called manic depressive illness. And this actually really is a concrete example of the recognition of severe mood disorders 350 years ago. Now, I saw Kraepelin was mentioned in the President's address. Kraepelin, who of course worked in Munich, he worked in other places, but he was most associated with Munich, along with Alzheimer and other landmark figures in psychiatry. And our current conceptualization of mood disorders, and indeed most of psychiatry, comes from Kraepelin. I've recently written an article which I don't think is published yet about the diagnosis of mood disorders, and we chose to call it Footnotes to Kraepelin. Just as some people say all of modern philosophy is footnotes to Plato, I don't think we've really fundamentally gone beyond Kraepelin's scheme. Just to say, of course, that classification did exist before Kraepelin. He brought together the notions of alternating mania and melancholia, folie circulaire by Fowley, into manic depressive insanity. And there was somewhat of a tweak, a minor change with that, with the separation of bipolar and unipolar disorders. And this is something which I think is still challenging, and indeed some researchers would say is still provisional. This was based on the work of Angst, Perez, Winokur and others about the familial loading of bipolar and unipolar disorders in families, with bipolar being commonest in both sets of probands, but unipolar being more common only in unipolar families. So what about the problems with diagnostic classification? Well, we've heard lots of these before, but it's worthwhile just going over them once again. And it's worthwhile also thinking about the underlying philosophy of science. Thomas Kuhn, The Structure of Scientific Revolutions, said, a scientific theory is declared invalid only if an alternate candidate is available to take its place. So it's fine to talk about the inadequacies of our diagnostic system, but to really replace it, we have to come up with something better. And that is our essential problem with psychiatric diagnoses at the moment. We're aware of the limitations, but we haven't found anything better. So the limitations are listed here. It's essentially descriptive. It was constructed in the age of steam. When we think about how the rest of medicine has changed in the last 30 years, never mind the last 130 years, it's striking how little has really changed with psychiatric diagnoses. These are syndromes which are poorly validated and are equated with diseases. There is both heterogeneity, where we have a category of disorders which undoubtedly has many different things going on, and the best example of this is major depressive disorder, which I will discuss. And we've also got pleiotropism, where an underlying disease process may manifest in different ways. And we see that, for example, with the evolution of bipolar disorder, which can present initially with anxiety disorders, addictions, depressive episodes, before fully unveiling as being bipolar with mania or hypomania. Very few categories meet validity standards, and the practice of psychiatric diagnosis was really depressingly bad up until operational criteria, which rescued psychiatric diagnosis in the 1970s. And I'll talk about this and about the role of Robert Spitzer and others. This has meant that we have reasonable reliability in research settings, but this is poor in clinical settings. So DSM, as you all know, was revised recently, and this was criticised as being really not necessary. I think there have been some good aspects of the revision for mood disorders, but I'm entirely sympathetic to the critics who say that there's no fundamental advance. There really hasn't as yet been proper diagnostic categories which have aided treatment selection or neurobiological research. There's an attempt to do that with the NIMH RDoC, or Research Domain Criteria approach, and I'll talk about that at the end of my lecture. Now, this man, Robert Kendall, who sadly passed away a few years ago, I think wrote the definitive text about the issues of the role of diagnosis in psychiatry. This book is out of print, but he did a number of articles which go over the same arguments. I went back to my copy of this when DSM-5 came out, because many of the criticisms that were made of DSM-5 by a variety of people, some of whom were frankly anti-psychiatry, struck me as having been covered by Kendall. And indeed, this book, if you can get a hold of it, is still well worth reading. He had a particular dispute with Thomas Saz, and to my mind, Kendall trounced Saz in the argument. But of course, Saz would never admit that. So what about diagnoses in psychiatry? Well, they're similar to the rest of medicine, but the rest of medicine has moved on very considerably in the past generation. And what we lack in psychiatry is biomarkers or physical investigations to supplement our diagnoses. As Kendall says, diagnoses are necessary to enable communication. Without diagnoses, psychiatric research and any approach to psychiatric disorders is like a Tower of Babel, where everyone speaks their own language. We know when I talk about major depression or bipolar 2 or bipolar 1 in London, Dr. Durson talks about the same in Calgary, or someone talks about the same in Istanbul or Izmir or Melbourne or wherever, we're talking about the same thing. And that's actually a significant advance. This allows research to proceed. So we often see trials from other parts of the world on various psychiatric diagnoses, and we never these days question if we're examining the same broad category. We know the reliability is reasonable for this. And as I say, once again, they have not been replaced by anything better. And this is the fundamental riposte to the critics of psychiatric diagnosis. Kendall says this in his book. He says, if there was something that was better, we would have adopted it. We don't particularly want to ride around in horse and cart. If someone invents a motor car, we'll go to that. But that has got to happen yet. So, in terms of the nature of affective disorders, it is undoubtedly a spectrum. This is one of the problems. Nature is dimensional, but we impose categories upon it. And it should be also noted that affective disorders also have comorbidities. One might think of this as almost an orthogonal axis going the other way, where you have relationships with psychosis, with addiction, and so on. The phrase which I have learnt in translation from Kraepelin is the well-founded moodiness of health, as you can see here. This, I think, is extremely important. It's extremely important that we recognise that one of the problems we have with all psychiatric diagnoses is drawing the line between health and disease. And I think this is lost in research. We sometimes see research where people talk about psychiatric illnesses almost being normal phenomenon. I think that is because they're confusing normal fluctuations of mood with illness. And then you can see within the spectrum we have unipolar disorder, bipolar 2, bipolar 1, but the boundaries between these are difficult. Now DSM, because of the categorical approach, has to put the boundary of the category, say, between bipolar 1 and bipolar 2, or between hypomania and mania somewhere, but these are, of course, provisional. Mood disorders are clinically heterogeneous, so as well as having what we might call psychopathological or emotional features such as low moods, suicidal ideation and so on, there are both physical and cognitive difficulties. And the area of cognition and problems with attention, concentration, memory and so on is one of the big growth areas in psychiatric research, particularly in mood disorder. So if we think about the introduction of operational criteria, I think the key date is really 1980 with the introduction of DSM-3, which was really led by this man, Robert Spitzer, who was a professor of psychiatry in Columbia, who passed away recently. And DSM-3 brought together the various previous research efforts, the US, UK diagnostic project, the St. Louis School, the research domain criteria, into an overarching operational criteria book. And really, DSM-4, DSM-4-TR, DSM-5 are tinkering with Spitzer's fundamental schema. So before DSM-3, DSM-2 and DSM-1 were essentially very difficult to be reliable because you could interpret the vignettes or text in any way that you wished. So it was rather surprising when DSM-5 came out that it produced quite a lot of controversy. And it came out in 2013. I was at the APA in the United States and the Scientologists were demonstrating. In London we had similar demonstrations. I had to go on the BBC numerous times, and that was one of the reasons that I put this lecture together. I went back and got my copy of the Role of Diagnosis down because psychiatric diagnosis was being attacked so much. And so much of the arguments were things that had been round the circuit before and been discredited. So thinking about DSM-5, we must go back to its predecessor DSM-4, and DSM-4 really didn't change the DSM-3 criteria. So mood disorders was divided into bipolar disorders, a group of disorders, and depressive disorders. It's noteworthy that bipolar disorders are not synonymous with Kraepelin's concept of manic depressive illness, because Kraepelin would have included a lot of recurrent depression in the manic depressive illness category. That's one important point to take note of. It's also true that in DSM-5 the symptoms or the criteria for a major depressive episode haven't been changed. So to remind you, these are depressed mood or anhedonia as hallmark symptoms, and then changes in weight, appetite, psychomotor function, so on and so forth. Now there is a critique by Edward Shorter, who's a historian of medicine, particularly of psychiatry in Toronto, published in the British Journal of Psychiatry, that is particularly critical about the criteria for major depressive episode and how this has made advances in understanding, particularly with the neurobiology and with treatment, difficult. And I urge you to go and read that. But essentially, Shorter's point is that prior to Bob Spitzer's work, we thought about numerous different types of depression. We thought about atypical, we thought about melancholic, and so on and so forth. But these have all been brought together in this one big category, which means that we're inevitably dealing with an incredibly heterogeneous disorder. So although a diagnosis of major depressive episode, which of course can be in major depressive disorder or bipolar disorder, must include a depressed mood, irritability or anhedonia, you can have increased weight or decreased weight, you can have insomnia or hypersomnia, you can have psychomotor retardation or psychomotor agitation. So the heterogeneity is really quite remarkable, and it amazes me as a field that we haven't looked at this in greater detail. So for example, my own group is very interested in atypical depression. This is where you have hypersomnia, you have you have lack of energy, you have increased appetite and weight. It's a well-recognized subgroup. Prior to DSM-3, there was quite a lot of work suggesting that this had a particular response to particular medications, particularly old irreversible MAOIs. This has been lost since DSM-3. The atypical depressions can occur within MDD or bipolar, and they appear to have a different profile, for example, of neuroendocrine function. So I think this is one thing that we've lost. However, DSM-5 does give us some way of parsing or subdividing major depression, major depressive episodes with the specifiers, and I'll talk about those in a moment. So what were the limitations of DSM-4 and indeed ICD for bipolar disorders in particular? Well, firstly, recurring depression was not recognized as a potential precursor of bipolar disorder. I'll talk about this in a moment or two when I talk about the evolution of bipolar disorder in an individual, but it's almost impossible to predict which depressions are going to turn into bipolar. 2/3 of people with bipolar 1 will have 2 episodes of depression before any episode of mania. And therefore, if you diagnose these people as being bipolar, you would be doing it on the basis of an absence of mania or hypomania. Angst and others have argued that the 4-day duration for hypomania is too long. Angst in particular argues the common duration is between 1 and 3 days. Drug-induced hypomania was excluded. There was a lack of recognition of subsyndromal forms of mania. In London, we find that these are often misdiagnosed as personality disorders, particularly emotionally unstable personality disorder, and this is very bad for treatment. Mixed symptoms, where you have some depression with mania or some mania with depression, are insufficiently characterized. DSM-4 was particularly weak at this. So, let's start with thinking about the reliability of DSM-5. And this is a summary graph from a paper, the DSM-5 field trials, New Blooms and Old Thorns, published in the American Journal 4 years ago, which looked at the inter-rater reliability in expert centres. And green is very reliable, blue is acceptable, and orange is unacceptable. And we can see in terms of mood disorders, bipolar 1 is the most reliable. I know from speaking to people who were involved in this that bipolar 1 would have been even higher, possibly the highest, but one expert centre performed very poorly. So that's interesting for 2 reasons. One, if you actually apply the criteria properly, bipolar 1 is really very reliable. But the other point is you can't even trust expert centres to necessarily do that. Looking at that expert centre, the criteria appear to be applied by the most junior members of the research team, and that was the weakness. We see that bipolar 2 is at the bottom of reliability, but interestingly ahead of major depressive disorder, which you can see is here. Now, a couple of other things I'd like to point out. One is that bipolar 1 is ahead of schizophrenia, but also schizoaffective disorder seems to be more reliable than schizophrenia. This is perplexing to many psychiatrists who aren't very familiar with the diagnosis, but nevertheless it comes out quite clearly. In terms of some of the other mood disorders, you can see that major depressive disorder is pretty unreliable. This, I think, gives a clue to some of the problems we've had with discovering new treatments. When you have a lack of reliability in the diagnoses, I think that contributes to the problems with separating active treatments from placebo. And lastly, you can see that mixed anxiety depressive disorder, which was dropped, had essentially no reliability whatsoever. So my take-home message from this is that within the limitations, bipolar 1, especially mania, is reliable. Schizoaffective is interestingly highly reliable. Bipolar 2 is less reliable than bipolar 1, but is better than major depression. So what changes were made for mood disorders in DSM-5? Well, firstly, there's a separate chapter for bipolar and related disorders from depression. Trish Suppes, my friend and colleague from Stanford, said that this is good because it gives more prominence to bipolar. I'm not sure. I think it creates an artificial division between bipolar and unipolar, which may not be helpful. Next, increased energy or activity was added as a core mood elevation criteria. So to be manic or hypomanic, you have to have increased activity. I think this is potentially very good. It's a way of discriminating subsyndromal forms from things like emotionally unstable personality, and it's also something that we can measure with actographs and Fitbits and so on. Mixed features specifier has been added, and I'll talk about this, but please note it's been added for manic, hypomanic and major depressive episodes, including major depressive episodes in MDD. So you can have mixed states in major depressive disorder. So you're not bipolar, but you can still be mixed. The antidepressant switching conundrum has been resolved. So if you have a full manic or hypomanic episode which emerges during antidepressant treatment and persists beyond the physiological treatment effects, usually 5 half-lives, for most of our medications about a week, if you persist in being manic or hypomanic, you can now say that's bipolar. Anxious distress specifier and a whole bunch of other specifiers have been added. I think these are good. Essentially, you have a core diagnosis of a major depressive episode, and then it can be subdivided with the specifiers. One of the proposed specifiers was for suicidality, but that was dropped, I think because of the liability issues, and that's a great shame. So this is the increased energy or activity. So as well as having abnormally and persistently elevated expansive and irritable mood, you've got to have increased directed activity or energy for mania for a week, for hypomania for 4 consecutive days. We've yet to see how this pans out, but I think it's likely that this will be helpful, particularly in discriminating between subsyndromal forms and personality disorders. What are the other highlights for mood disorders? Well, there's a couple of new disorders. One is disruptive mood dysregulation disorder. This was brought in an attempt to resolve the issue with childhood bipolar disorder. I'll talk about that in a moment. Premenstrual dysphoric depression was added. This isn't really new. It's been in DSM before in various study categories, but I think it's a welcome addition. There's a replacement of dysthymia and chronic major depressive episodes with persistent depressive disorder. Again, I think that's good. Mixed anxiety depression was abandoned because of low reliability, but remember the anxious distress specifier is still there. There's a couple of other issues. Major depressive disorder, there was a issue about the bereavement exclusion. I'll talk about that in a moment's time. And the mixed feature specifier can be applied here. So it's just worthwhile emphasizing this once again. You have major depressive disorder, you don't have bipolar disorder, but you can still have mixed features. I think in a way this is good because it recognizes a category which is clearly there, but because of the separate chapters, it suggests that this is somehow different from bipolar disorder, whereas most of us would regard it as being part of the same spectrum. So this is disruptive mood dysregulation disorder. This, as you can see, is pretty new. It encompasses temper outbursts. The mood between temper has to be persistently irritable and angry. The duration is 12 months with no period of 3 months or more. The age of onset is not before 6 or not after 18. This was necessary because in certain research centers in the United States, particularly Boston and Pittsburgh, there was an explosion of diagnoses of childhood bipolar disorder. Now, this wasn't paralleled in Canada, as far as I'm aware, or in Europe or Australia or anywhere else. Indeed, if you look at the writings of Kraepelin, he said quite specifically that although childhood mania did occur, it was very rare. And full onset of mania in careful studies of high-risk groups such as Anne Duffy's in Canada, Katerina Reichert's in Europe, who look at the children of bipolar disorder, they haven't, to my knowledge, reported mania before the age of 15. This is Kathleen Merrick-Angus's onset. Now, this is the first occurrence of either a manic or a hypomanic episode or depression. And most of these will initially be depression. And you can see pre-pubertally this is very rare, but builds up, of course, over adolescence. And this is the basis of the oft-quoted fact that the majority of cases onset by the age of 25 or 30. The problem with this is that lots of other things onset then as well. So this is the work of Jacobi and colleagues. You can see this is rather unclear, but I haven't made it any clearer because the point is that in the in adolescence, in the second decade of life, second and third, we have an onset of anxiety, depression, substance misuse, so on and so forth. And separating these out at the early stages without longitudinal follow-up is really very difficult. So the criteria for disruptive mood dysregulation disorder have yet to be really tested. There's one very interesting paper that I'm aware of that looks at the families of people with bipolar disorder, and the incidence of this disorder does not appear to be increased. So that's very interesting. That's got to be confirmed, but that does suggest that this is separate from a mood disorder per se, perhaps more related to conduct disorder or some other childhood disorder. Premenstrual dysphoric disorder. I've actually done a fair amount of research on this. This is very interesting. It seems to be related to serotonergic function. Our own research has shown that pure premenstrual dysphoric disorder is quite rare. It's usually a premenstrual exacerbation of an ongoing low-grade mood disorder. But nevertheless, this is interesting. Work in Canada and McMaster by Professor Steiner showed that the response to SSRIs is very quick with PMDD. It occurs within a day or two, which is really much faster than in depression. Persistent depressive disorder. This is a consolidation of dysthymia and chronic MDD, both of which had a duration of 2 years. It involves depressed mood for more days than not for 2 years. And you can see the symptoms there. And there's additional exclusion criteria. This looks at the conceptually difficult and overlapping areas of severity, treatment resistance and chronicity. Severity, of course, is defined by a snapshot of symptoms. Chronicity relates usually to 2 years or more, and treatment resistance is something else. This is defined as failing at least 2 adequate treatments, but encompasses a whole range of resistance. We've got a paper that's in press trying to define treatment resistance more adequately. There's been attempts to do staging of this, for example, the Maudsley staging model and so on and so forth. I hope that persistent depressive disorder will provide a category that helps people study these areas more reliably. Oops. Now, the bereavement controversy. This is something which caused great feeling. There was a belief that psychiatrists were saying that grief and depression are the same thing. And this perhaps can be traced back to Freud's classical essay, Mourning and Melancholia. But the difference, the actual issue about the change in DSM was that you previously could not be diagnosed with a depressive episode if you were bereaved. And this is clearly nonsense because we allow other life stressors as precipitants. So nobody is saying that bereavement is the same as depression. It's quite clearly different. But also, it's really not helpful to say that if you're bereaved, you can't be depressed. And please note that it says the decision inevitably requires the exercise of clinical judgment based on the individual's history and cultural norms for the experience of distress in the context of loss. So I hope this will perhaps even allow some studies to be done of people who are suffering from post-bereavement depression, because antidepressants are used very commonly in this clinical scenario. What about affective states, mixed affective states? Well, Kreppelin's concept of this was far more sophisticated than DSM-4. He conceptualized not only mood cycling up and down, but also volition and thought processes and so on, giving a range of mixed states from pure mania to pure depression with all of these interforms here. Now this, of course, wasn't based on modern statistical techniques, but rather very skilled clinical observation, but has stood the test of time and was really neglected in DSM-4. So, DSM-4 has included specifiers, one of which is mixed features, which I'll go through, but it's worthwhile noting that all of these apply to major depressive disorder and bipolar disorder with the exception of rapid cycling. And some people would argue that you can get rapid cycling unipolars. So I think these are quite good. These are extra ways of sub-classifying the depressive episode that may give an answer to Shorter's criticism about the heterogeneity of this broad group of disorders. It's quite clear that mixed states are quite common in mania. You can see here a number of recent studies showing significant depressive symptoms in about a third of people with mania, whether it's 2 or 3 depressive symptoms, and these seem to alter treatment responsiveness. And it's also true, and I mention this again, that you can have a major depressive episode with mixed features not only in bipolar disorder, but also in MDD, where you don't satisfy the criteria for bipolar disorder overall. What are the implications and the meaning of mixed features? Well, diagnosis is certainly more accurate. You may be able to study prodromes of bipolar. There may be clinical phenotypes that map on to biomarkers. It may give us tighter diagnostic categories for trials. So, for example, Trish Suppes has published a study with lurazidone. It's now published in the American Journal, which was specifically on major depressive episodes with mixed features. Remember, major depressive disorder or major depressive episodes is a real problem with separating drug from placebo. But the separation in this group was really very clear indeed. So this may be something that impacts on licenses and regulatory agencies. Depression and personality. I think DSM-5 for personality in general probably fails and is going to be very different from ICD. In ICD, Professor Peter Tyrer, my colleague from Imperial, is introducing a radically new system looking at domains and so on, and they are planning on dropping all of the old categories such as borderline and so on and so forth. DSM hasn't done that, and if there's one word which is notably absent from this slide, it is neuroticism. Neuroticism, one of the big 5 personality domains, first shown by Eysenck and then Jeffrey Gray, which is probably the personality variable which is most related to mood disorder, is missed entirely here. And I think that's a big miss. Moving on to ICD, I've talked a lot about DSM, and DSM occupies a big part of the literature. But remember that for the world in general, ICD is the diagnostic classificatory system, and that also applies to the US. The reason that DSM is so prominent in the US is because that's what the insurance companies want, but the US government and also the Canadian government want the diagnostic classification in ICD terms because that's the official preferred diagnostic system for all members of the United Nations. This evolved over a period of time. ICD-10 is actually quite old. We're expecting ICD-11 anytime soon, but it hasn't quite arrived yet. This is the relationship between ICD-10 and DSM-5. They're both used. Generally, they're pretty similar. I would expect ICD-11 to be very similar in terms of mood disorders to DSM-5. As I've said, the one area which I think is going to be different is personality and personality disorders and dysfunction. And we'll have to wait and see how that comes out. It's also worthwhile noting that whereas DSM is a product of the American Psychiatric Association, ICD is produced by the WHO and covers all diseases, not just psychiatric diseases. You can see mental and behavioural disorders are one of the chapters. But mental and neurological disorders are admitted by the WHO to put greater disease burden than any other category except communicable diseases. And communicable diseases, even in sub-Saharan Africa, are relatively dropping. So I think the bad news is that we're going to actually see psychiatric disorders occupying an even more prominent position in terms of burden of disease over the course of the next couple of decades. The good news is that as clinicians and researchers, we should be very busy. And you can see here affective disorders that you know very well. There are cultural issues in ICD. Psychiatric diagnosis is cognizant of cultural, social, biological and psychological factors. There's increased interest in the cultural framework of prospective diagnostic systems. The President mentioned Arthur Kleinman, and Arthur Kleinman really did very interesting and fundamental work about the role of culture. And I visited the field stations in southern China, where when Kleinman first went there, depression wasn't diagnosed at all. It was all diagnosed as neurasthenia. So part of this is the use of the tools, as well as the expression of the underlying disorders. And you can see here a number of culture-specific disorders in ICD-10, Malaysian, Indian, and so on. There's a possibility that for ICD-11 we may put in Brexit as a UK-specific mental disorder. I'm not sure whether that will happen or not. It's also possible that voting for Donald Trump will be a US psychiatric disorder. So, for example, in terms of regional and national adaptations, these are possible. Chinese classification, Japanese, and so on and so forth. It's true that transcultural aspects of mood disorders are extremely important, and I've brought out some of the epidemiology here. So I've said that when I'm diagnosing depression or mania in London, and Dr. Durzan is in Calgary, and perhaps Professor Silverstone is in New Zealand, and so on and so forth, we're all talking about broadly the same thing. But the epidemiology is different for depression. There's a classic paper by Myrna Weisman. The lifetime rates for major depression vary widely across countries, ranging from 1.5 cases per 100 adults in Taiwan to 19 cases per 100 in Beirut. There's undoubtedly an effect of societal disruption, stress, dislocation, war, and so on. But there's also an effect of culture. For any of us who've dealt with large populations of people from East Asia, the expression of symptoms is a lot different from, say, Western Europeans. However, it's noteworthy that in every country the rates of major depression were higher for women than men. This may be partly societal, but it also may be related to neuroendocrine variables such as progesterone. However, it seems to be different for bipolar, particularly bipolar 1. The lifetime rates of bipolar disorder were more consistent across countries. We've actually done a recent review of this and found the same, where the sex ratios are nearly equal. This is particularly true for bipolar 1, less true for bipolar 2, so there seems to be a spectrum of reliability and difference in the expression. ICD-11, this is due out soon, hopefully, and we'll see what's going to happen there. What about the impact on research? Well, I think this is crucial for all of us. The reason I give this lecture is because no one else seems to be giving a lecture about diagnoses. And I think it's important to be aware of both the strengths and weaknesses. Low reliability of diagnoses may compromise research. That's, for example, most true with depression, least true with mania. Dimensionality, which we've heard about, poses problems for trial inclusion. I think it's very important that we're aware of that. Perhaps the DSM specifiers may actually help there. But we should be aware that our diagnoses are not empirically based nor adequately tested for validity. And this inevitably awaits more neurobiological research. There are new populations for clinical trials and epidemiological studies. For example, I've mentioned a very nice paper from Eastern Canada, which is not published yet, but shows that the rates of disruptive, the childhood disorders, the disruptive disorder, are not increased in families where the proband has bipolar. So that's already interesting information. It's also true it's unclear whether changes in prevalence will be due to changes in diagnostic criteria or increased representation of the disorder. I think we're seeing that with the increase in prevalence in young people. And studies may need to be done to reflect changes in diagnoses. Moving on to the last few minutes of my talk, I want to talk about the NIMH research domain criteria. This was introduced by Tom Insel when he was head of NIMH. And this was an attempt to cut the Gordian knot of diagnoses for neurobiological research. Tom Insel, of course, has gone on to Google, to Alphabet, but I think this was a very brave attempt. The effort, it says, is to define basic dimensions of functioning, such as fear circuitry, working memory, so on and so forth, perhaps psychotic symptoms, to be studied across multiple units of analysis, from genes to neural circuits to behaviours, cutting across disorders as traditionally defined. And I don't think that's something that anyone would argue with. Many of us were doing this already, and I would argue that even if you research within the spectrum of affective disorders, you are researching across categories as traditionally defined. The intent was to translate rapid progress in basic neurobiological research and behavioural research to an improved understanding of psychopathology and then develop new treatments. Now that sounds great. Unfortunately, it hasn't quite worked out. I'm not really aware of any fundamental advances that have happened, although the work is still ongoing. So to just show you a brief schematic, we have the domains and constructs here: threat, fear, reward, attention, so on and so forth, and then we look at that in terms of genes, molecules, cells. My own view is that this is a vital approach, but we should do it with our diagnostic categories. So I would say that this doesn't replace diagnosis, this is a way of augmenting diagnosis. So for example, with genes, we look at genetic loading for depression, in schizophrenia, and bipolar disorder, and so on and so forth. So I think the best way forward is to use all of the tools that we have available and to use research domain criteria as well as diagnostic categories. I think the future is undoubtedly biomarkers. This has revolutionized the rest of medicine, but it's done it in a very particular way. If we think about cancer, cancer treatment is very different from the way it was a generation ago. As a young doctor, I worked in a cancer ward, and the treatments that we gave were very broad and non-specific. They were cytotoxic drugs, which made the patient very sick, or they were radiotherapy. But now we have very pinpoint treatments, but only for certain cancers. So cancer isn't one particular disorder. Even breast cancer, for example, biomarkers such as the estrogen receptors can tell us separate subcategories where some treatments may work. But those treatments are not going to work in the people who do not have the biomarker indication. So I think it's inevitable that our broad diagnostic categories, remember cancer was a very broad category. People talk about curing cancer, but there's really many, many, many different cancers. So lung cancer, for example, there's a form of lung cancer which is not related to smoking. and this appears, there's a new drug from AstraZeneca, where the survival of people with this has been markedly increased. But very, very surprisingly, about 10% of individuals appear to go into remission, something that would have been unthought. But that drug is not going to help people with colon cancer, for example. So I think biomarkers are the way ahead. They're defined as a characteristic that is objectively measured, evaluated as an indicator of normal biological processes, pathogenic processes, pharmacological responses to a therapeutic intervention. They go from discovery, confirmation, validation, adoption, and then they're used in therapeutic studies. I've talked about cancer, but there's a very good approach shown in also immune disorders, such as rheumatology. This is the stratified medicine approach, sometimes called precision medicine, where you take the group of individuals with a disease, you analyze a biomarker, and then you predict treatment based on the biomarker. So, for example, we can see here patients who present with inflammatory arthritis or new onset rheumatoid. You look at the biomarkers, and you can then predict whether you give methotrexate, anti-TNF agents, or other therapeutics. Similar conceptual approach with many cancers related to biomarkers. There's numerous approaches to trying to use this in psychiatric disorder. I head up the therapeutics part of our biomedical research centre, but we have a very large equivalent group doing precision medicine, which is everything from genetics, neuroimaging, and so on and so forth. I think one of the hopes is for neuroinflammation. This is, I was talking to one of my colleagues about this earlier on. We're doing a lot of work on this. I think this is something that can be done in basic animal models. And I think if you had to pick one biomarker group that was likely to help us clinically in the next 5 or 10 years, neuroinflammation would be a reasonable thing to do. However, unfortunately, just at the moment, it's still at the stage of confusion. But I think there's so much work going on here that we're bound to get something useful and tractable. We've just published a paper, for example, showing that people with increased neuroinflammatory markers are less likely to respond to lithium. So I think this is going to play out across the range of mood disorders. So to conclude, I've done a very broad-ranging resume and apology and defence for diagnoses, particularly with mood disorders. Mood disorders have a long history as a clinical concept, and I think may be universal. So some of the other problems, for example, we have bulimia nervosa was described in our hospital only a generation ago. Hoarding disorder attracted particular opropium in DSM-5 because it's a new concept. Adult onset ADHD, a relatively new concept, and so on and so forth. Even schizophrenia can't be traced back more than a few hundred years. But mood disorders, unfortunately, have always been with us. The diagnostic systems, DSM-5, ICD-10, 11, have not been superseded. This is the great argument against the anti-psychiatrists and the people who would pull down the edifice which Kreppelin built. That's fine, but you have to have something better. I think ICD may gain primacy over DSM in clinical practice. We'll wait to see how fit for purpose ICD-11 is, but certainly it will be used internationally a lot more and may therefore influence both research and regulatory affairs. NIMH research domain criteria is a novel approach which I think is best used in a complementary fashion to the categorical approach. Particularly in terms of mood disorders, bipolar disorder is more reliable than MDD, with mania being the most reliable. MDD is a heterogeneous rag bag. Subclassification is long overdue, but the specifiers, I think, will be very helpful here. We've already seen this with the lurazidone trial. Biomarkers, I think, will eventually impact psychiatry as they have in the rest of medicine. The advances, particularly in cancer and rheumatology and autoimmune disorders, have really transformed those fields, and I think we will inevitably see that in psychiatry. But I would imagine it will also be like what's happened in cancer. There won't be one overall cure for depression. We will find particular subtypes defined by biomarkers which are responsive to particular treatments. And lastly, I would urge all of us to be aware of the fact that scientific progress depends on getting diagnoses right. This is irrespective of whether it's clinical trials or extrapolating back into the lab and looking at processes in animal models. So I'll stop there, Teshakurdam, and thank you for your attention.